Hi, this is the recording for drugs of the endocrine system, and although it says drugs of the endocrine system, it should be some drugs of the endocrine system, because we're really going to cover three groups of drugs. The first group of drugs is drugs that affect dysfunction of the adrenal gland, and specifically the adrenal cortex. And then the second one is dysfunctions that affect the thyroid gland. And then the third endocrine disorder that we're going to tackle in this lecture is diabetes. So let's get started. So this is just an overview slide comparing hormones and neurotransmitters, because there are quite a few similarities between hormones and neurotransmitters, but there are also some differences. So let's go to the similarities first. All right, both hormones and neurotransmitters bind to and activate receptors on target cells to modulate intracellular signaling pathways. So basically what happens is that whether it be a hormone or a neurotransmitter, the ligand binds to a specific receptor, and the binding of the ligand to the specific receptors basically evokes some changes inside the cell. All right. And that's what it says in the second point, that both can alter cellular, tissue, and even whole body physiology. So we think about hormones like the growth hormone that affects the entire body in terms of the muscle and skeletal growth. We think about thyroid hormones that can actually affect blood pressure and cardiovascular parameters, as well as basal metabolic rate and a whole host of other factors. So there's a whole range of different effects that both hormones and neurotransmitters can do. And again, with neurotransmitters, you think about you think about the sympathetic nervous system with the release of norepinephrine and epinephrine that also causes changes to the entire body in terms of how it responds. So quite a few different hormones as well as neurotransmitters actually have different effects on different tissues, and we'll look at that as we go through this lecture. Now, there are some differences between hormones and neurotransmitters. The first one is that hormones, by their very nature, are produced by one endocrine gland, right? So they're produced over there, and then they travel through the systemic circulation to have their effect on the target tissue. And so their effect can be more extensive because they're circulated throughout the body, whereas neurotransmitters are released by a nerve, and the target tissue is just right next to it. Right? So it's a short duration of action for neurotransmitter, long duration of action for hormone. Neurotransmitter has got local effects, whereas hormones can have more extensive effects because of their circulation throughout their body. Most hormones bind to transport proteins from which it must dissociate to interact with specific receptors. So if you look on the picture at the bottom, what you see over here is where it has number 1 over here. That big blob is a plasma protein that actually carries some types of hormones, and some types of hormones that it carries are steroid hormones, so they would be the sex-based hormone, as well as cortisol and aldosterone, and also thyroid hormones. And then when it reaches close to its target tissue, what happens is it dissociates from the transport protein, and then it can actually enter through it can leave the blood vessel, enter into the cell, where it has an effect on the receptor. And that leads to the second difference between hormones and neurotransmitters. In the top diagram on this page, what we see here is there are two types of hormone depending on their structure. We've got water-soluble hormones whose receptors are on the cell membrane, because the water-soluble hormone can't actually get through the lipid bilayer. And then you've got fat-soluble hormones that are transported through the circulation via these transport proteins, and because they're fat soluble, they can actually cross into and bypass, go through the lipid bilayer, and the receptors are somewhere inside the cell. So it can be either in the cytoplasm, as you can see there, or it can be actually in the nucleus itself, right? And hormones, the effects can be either acute or it can be chronic. So it can have a very quick effect, or it can have an effect which may not be felt for hours or days after the receptor has been triggered. These are some physiological function of hormones, and again, what we're going to restrict ourselves to in this lecture is a discussion on thyroid hormones, on dysfunctions of adrenal cortex hormones, as well as diabetes. So, what kind of changes can happen with all hormone function, and how are these changes? How do these changes occur? Well, first of all, is that the changes in the hormone function can be altered circulating hormone levels of hormone. And altered means that there can be a decrease in the number of hormones, or there can be an increase in the number of hormones. Right? And so what happens is it can be due either to a dysfunction in the amount of hormone that's released. It can be due to the way that the hormone is travels within the systemic circulation, and this is especially pertinent in steroid-based hormone, because in some disorders where liver function decreases, basically the liver is the organ that actually makes the transport protein. And so if liver function decreases, the amount of transport protein also decreases, and so the amount of steroid hormones that can be found in the circulating bloodstream is also lower. Okay? Metabolism of the hormone can actually also impact. So if you decrease metabolism of the hormone, that means you basically lead to an increase in the amount of active hormone around, and the reverse is true. And excretion is also another variable in actually affecting the levels of hormones. So again, if you decrease excretion, then you increase the amount of active hormone that's present, and the reverse is true. Sometimes there might be other cells or tissues in the body that actually secrete that hormone. And the problem with that is that this tissue is not under normal regulatory control. So within the hormonal system, there is quite a few negative feedback system, but the negative feedback system only works on normal endocrine tissue. So sometimes you have an ectopic production of hormone, and this ectopic production of hormone is not under normal feedback control, right? And so you have a change in the levels of hormone. Now, another reason for changes in hormone function is that there might be a change in the target tissue hormone sensitivity. And so what happens is that the amount of hormone that's floating around may be fine, right? There might be just a normal amount of hormone floating around. There might be even a little bit too much. But what happens is the receptors that the hormone binds to is somewhat altered. And so what happens is, instead of the hormone binding easily to the receptor is somehow defective, so that the hormones can't actually bind to the receptor. Right? So that's one change in terms of the target tissue hormone sensitivity. The other possibility is that the hormone binds fine to the receptor. So the hormone binds fine to the receptor, but somehow what happens inside the cell is changed. And so what happens when that occurs is that the cellular response of the hormone, of the tissue to the hormone, is decreased. All right, and then sometimes what happens is there might be less receptors actually found, because these membrane receptors are actually proteins that are made by the cell, and the number of receptors on a cell can actually fluctuate, can actually increase or decrease, and that decrease or increase, that change in the number of receptors, may actually affect the cellular response. All right, so these are the various ways that hormone function can be changed. So some strategies to treat hormonal imbalance. So the first one is how do you increase the amount of hormone that's present, or the activity level of the hormone that's present. So this is usually used in condition where there's a decrease in the number of hormone, right? So if there's a decrease in the number of hormone, then what you want to do is you want to increase, by some means possible, increase the amount of hormone produced, amount of hormone release, amount of hormone being transported in the circulation. The second thing is that you've got the production of hormone, right? And then it's released, and then it's transported, and then at some point it's metabolized and then excreted, right? So if the amount of hormone that's found in the blood is reduced, what happens is you need to somehow either increase production, increase release, increase transport, or you can decrease the amount of hormone metabolized, and you decrease the amount of hormone excreted. And if you do any one or a combination of each of this, what happens is the amount of hormone present will actually increase, hopefully back to normal, right? And then another, so this is one strategy, which is that. And then another strategy is to give that person hormone replacement therapy, right? So if there's a decrease in the amount of hormone, then you give hormone replacement therapy, and it brings the hormone levels back up to normal. All right, so that's a strategy to actually treat hormones that are not produced in sufficient quantities. Now the second one is used to treat hormones where there is too much around, right? So what happens if there's too much hormones around? So one of the strategies is to actually remove that endocrine gland, right? So remove endocrine gland. And then another strategy is to decrease production of hormone, decrease release of hormone, right? Decrease conversion to activated forms, decrease transport, increase metabolism, and increase excretion. And so if any one or a combination of these actually happen, then what happens is hormone levels will actually drop back to normal. Or, like I said, you basically remove the endocrine gland, and then you give hormone replacement therapy to a more normal level. All right. Another strategy that is used to decrease hormone levels and activity is to actually decrease the receptor number, or the affinity of the hormone to the receptor. So again, if you have a receptor over here, you have the hormone, and if you can actually change amount of hormone that's produced, what you can do is you can decrease the number of receptors or decrease the likelihood of the hormone binding to the receptor. And that's what it means when it says decrease affinity of the hormone to the receptor. Another strategy is to actually give antagonists. So you give a different kind of drug that basically binds to the receptors but actually does not activate that receptor, right? So, or another strategy is to look at the changes inside the cell and to actually block those changes at some point within the intracellular pathway. All right. So those are some strategies to actually decrease the either the hormone levels or the activity levels of the hormones. First kind of disorder we're going to talk about involves the adrenal gland, and specifically the adrenal cortex, right? So the cortex is the outer layers of an organ. The medulla, the inner layer, actually is involved in producing catecholamines, and the catecholamines are epinephrine and norepinephrine. But in terms of the adrenal cortex, it produces 3 different types of hormones. It produces aldosterone, which is the main mineralocorticoid, and that's involved in the renin-angiotensin-aldosterone system. You've got cortisol, which is the main glucocorticoid, and you've got androgens, which are sex hormones, and it normally plays a fairly minor role in the overall effects of sex hormones. So usually, because other sex hormones are produced, testosterone, progesterone, and estrogen, those play a much more major role than the androgens that's produced by the adrenal gland. All right? So what we're going to talk about is we're going to talk really about aldosterone and about cortisol. And you can see over here just the pathway over here. So they're released in times of stress, causes the hypothalamus to release CRH, and the CRH travels from the hypothalamus via the portal system to the anterior pituitary, and then specific cells, corticotrope in the anterior pituitary, release a second hormone called ACTH, and ACTH then travels in the systemic circulation where when it goes to the adrenal cortex, there are receptors for ACTH on the adrenal cortex, and then that stimulates the release of aldosterone and of cortisol. And these are the effects of aldosterone in a normal situation, and these are the effects of cortisol in the normal situation. So you can see over here, aldosterone results in sodium and water retention, increase in blood volume, increase in blood pressure, whereas cortisol results in an increase in glucose, right? Increase in blood glucose levels, and it also suppresses the immune system. So, cortisol, so this is the therapeutic overview. So you've got glucocorticoids. Glucocorticoids are administered when there's not enough, when a person doesn't have enough cortisol produced endogenously. And one of the conditions where this happens with adrenal insufficiency is called Addison's disease, right? And as I said before, glucocorticoids have it suppresses the immune system, so it's used as an anti-inflammatory, anti-allergy, and to actually suppress the immune system in specific situations, like in transplant situations. And what happens is there are some adverse effects. So the adverse effects are really when a person is given too much cortisol, right? And so you can end up with Cushing's syndrome, and one of the hallmarks of Cushing's syndrome is that that person has got an increase beyond normal levels of cortisols being released in the blood, or it can actually lead to a suppression of the adrenal gland release of cortisol. All right, so what happens is if you have an increase in glucocorticoids, either because in this case, because that person has been given cortisol as a treatment, what happens is it basically shuts down this negative feedback pathway. And so what happens is when this negative feedback system is suppressed because there's too much cortisol produced, is that the adrenal cortex then doesn't work well. It's suppressed because there's too much cortisol floating around. Okay. Now, second group of drugs are mineralocorticoids. So the replacement, again, replacement therapy for adrenal insufficiencies for people who have a decrease in the amount of aldosterone released. And what happens is when you have an increase in mineralocorticoids, right, what happens is then that person can end up with an increase in blood pressure, and that can lead to edema, and it can lead to cardiac enlargement. All right, so these are, the first two are hormone replacement, effectively hormone replacement therapy. The next two is what happens when there's too much, right? So basically, in cases of Cushing syndrome, where there's too much cortisol released, what happens is that the amount of glucocorticoids can be inhibited, right? The synthesis of the glucocorticoids can be inhibited. So there's decrease in cortisol synthesis. Or what happens is the receptors for the cortisol or aldosterone is actually blocked. And so there's no effect in the cell when it's actually activated, right? So it's blocked by antagonists, and so the effects are decreased. And you can see here, this is usually done when there's too much glucocorticoid or there's too much mineralocorticoid. So an excess of cortisol release or an excess of aldosterone release. All right, second hormone dysfunction has to do with thyroid hormone. So again, what we've got over here is just an overview of thyroid hormones, principal actions. So there's two different types of thyroid hormone, T3 and T4. So T3 has 3 iodine attached to it. T4 has 4, right? T3 is more potent than T4, but T4 is more plentiful than T3. So there's more T4 around, but T3 is the one that's much more potent. And then T3 is usually made by conversion from T4. And so you've got here just a negative feedback system. You've got a hypothalamus releasing TRH, and that travels to the anterior pituitary, that then releases TSH, that travels to the systemic, through the systemic circulation, where there are receptors on the thyroid, and that causes the release of T3 and T4, and then it leads to biological effects. All right, so again, this is just what happens inside the thyroid gland. You can see T4 is converted into T3, and then T3 binds to the receptors that are found in the nucleus over here, and then it leads to changes in protein synthesis, right? Changes in transcription and translation, and therefore changes in the synthesis of new proteins. So the biological effects of thyroid hormones are growth, development of the central nervous system, cardiovascular effects, as well as metabolic effects. So disorders of the thyroid gland are either too little thyroid hormone secreted or too much thyroid hormone secreted, right? So too little is hypothyroidism, very common. Too much is caused by is called hyperthyroidism. All right. So too little thyroid hormone can be caused by either the thyroid gland not working itself, or the pituitary gland not working, or the hypothalamus not working. Because as we can see in the previous slide, you've got these three endocrine glands that are involved in regulating the release of thyroid hormones. In terms of hyperthyroidism, what it can be caused by is it can be caused by something called Graves' disease. And what happens in Graves' disease is that there are these antibodies that are made by that person's body called TSI that basically can also bind to the same receptors that TSH binds to on the thyroid gland, right? And the effect of TSH and TSI binding to the TSH receptor is the same. What happens is when either of them binds to the TSH receptors, it leads to an increase in thyroid hormone release. A second reason for hyperthyroidism is then there's a goiter, a nodular goiter on the thyroid gland, and that also causes an increase in the thyroid hormone secretion. A third one is that you've got an adenoma, right, a tumor of the thyroid gland, and that causes an increased release in T3 and T4 because it's not under normal regulatory feedback. Or if someone has been taking too much thyroid medication, and that means that there's too much T3 and T4 floating in the blood. All right, and what you can see here is you've got a person split in half. The symptoms that are listed on the left-hand side are the symptoms associated with hypothyroidism. Symptoms listed on the right-hand side are related to hyperthyroidism. So, what kind of treatments happen with hyperthyroidism? All right, so one of the big things is that if you look at the effects of thyroid hormones, so we'll go back a couple of slides. If you look at the effects of thyroid hormones, you see over here that thyroid hormone have got cardiovascular effects, as well as it's got very similar effects to cortisol. And so what happens is that one of the treatments is that you actually give that person beta antagonists to basically reduce the tachycardia as well as reduce the tremors of the skeletal muscle. You give them glucocorticoids to cause a decrease in the core body temperature because thyroid hormones increase basal metabolic rate, right? And it also glucocorticoids have been shown to slow down the breakdown of T4 into T3. So if you slow down T4 catabolism, then you decrease the amount of T3 that's actually produced and can have an effect on the target cells. Right? Another strategy would be to give a drug, propylthiouracil, that basically decreases thyroid hormone synthesis. Right? So if you decrease synthesis, you decrease the amount of T4 and T3 produced. Another strategy is if there's an adenoma or a cyst, that you remove that abnormal tissue, right? Especially if there's a well-defined mass. A fourth strategy is to actually give radioactive iodine, and that basically acts to actually kill the endocrine gland of the thyroid gland. Right, the endocrine tissue of the thyroid gland. And just note, the best candidates for radiation ablation is patients over the age of 30. And contraindications is that you don't want to give it in to women that are pregnant, because that might affect the growth of the fetus, and you don't want to give it to women who are breastfeeding, because it can be transferred into the breast milk and then end up going into the fetal circulation and basically killing the fetal thyroid tissue. And that's also very dangerous because, especially in the first few years of life, the thyroid hormone is involved in developing the CNS. And if there's too little thyroid hormone floating around, it can cause severe mental retardation that the child cannot actually make strides against later in life. Now, with surgical ablation and radiation ablation, what happens is it basically kills off the thyroid tissue, and so you need thyroid hormone replacement therapy after that tissue has been removed, either surgically or via radiation ablation. Now, so it brings us to this slide where it talks about replacement therapy for thyroid hormones. So this is used, as I said, after surgical or radiation ablation when a person is hyperthyroidic, or it's given as a replacement therapy for a person who's hypothyroidic, right? And the drug of choice is called Synthroid or levothyroxine, and its Synthroid is made of only T4, right? And so T4 is ingested, and then in the body it gets converted to T3, which is the more active compound. All right. Half-life is 7 days because this T4 is bound to protein. So it takes a while for the protein to actually for the hormone to be detached from the protein and to leave the system. Very important. Take orally. It's usually given orally, and you need to take it on an empty stomach to improve the absorption. If not, if you take it after a meal, what happens is that person will have very, very expensive urine, right? Drug interactions are drugs that reduce absorption of the thyroid pill, drugs that increase metabolism of the T4, as well as warfarin that actually accelerates, and it has drug interactions with warfarin, basically because warfarin is also a protein-bound drug. So again, if you give too much Synthroid, it can lead to effects that are associated with having too much thyroid hormone around, which is tachycardia, possible angina, and tremors. All right, there are a couple of other drugs. There's liothyronine that contains only T3, and this is given when a person cannot convert T4 into T3, right? And then there's also Liotrix that's given as well, and that has a mixture of T3 and T4 around. The third and last the third and last endocrine condition is diabetes. So again, just overview, you've got type 1 diabetes and type 2 diabetes. And the problem with type 1 diabetes is that there's either little or no insulin produced. So the treatment for type 1 is to give that person insulin. For type 2 diabetes, insulin may be present. In fact, insulin levels can be either low, normal, or too high. But what happens is that the receptor doesn't recognize insulin, and so that's called insulin resistance, right? So the treatment for that is to actually improve the insulin sensitivity through a weight loss program with diet and exercise, or some of the drugs that are given also decrease the amount of carbs that's absorbed in the digestive tract, or it decreases the amount of glucose that's produced by the liver. Now, diabetes, a person will have for life, and it needs to be managed very, very carefully, because if that diabetes is not managed, what happens is you have chronic conditions that are caused by a lack of management of diabetes. And so you can have damage to the microvascular system, so this is damage to the capillaries. And in terms of damage to the capillaries, basically it's due to a lack of a reduction of nutrient supply to tissues. And so what happens is that that person can end up to be legally blind, retinopathy. That person can actually lose sensation and lose motor control of their various glands and organs and muscles. And that person can actually end up with damage to the kidneys, nephropathy. And in fact, it's been shown that diabetes is responsible for causing around about 40% of kidney failure. In terms of macrovascular damage, it's damage mainly to the larger arteries and arterioles. And basically, the macrovascular damage is due to an increase in lipid around, and that basically leads to atherosclerosis and the complications associated with atherosclerosis. So it can cause coronary heart disease, or it can cause peripheral vascular disease. I won't actually get into that because that's a subject for pathophysiology later on. So I talked about insulin, and insulin is a hormone that's produced by the pancreas. So you've got here the pancreas over here, and so what happens is insulin is produced by beta cells, and glucagon is also produced by the pancreas, and those two hormones, glucagon and insulin, basically regulate blood glucose levels. And so if you look in the picture on the top right, you've got normal blood glucose range is the one in blue, and so what happens is as glucose levels rise, what happens is that insulin is released and then it drops, right? And if it drops too much, what happens is glucagon is then released. Glucagon is released to try to increase blood glucose levels and brings it up. And then again, insulin is released over here, bring it down. It's too low, then glucagon is released over there to bring it up. It gets too high, insulin is released over there. Gets lower, glucagon is released over there. Right? So there's a balance between the release of glucagon and insulin to actually keep blood glucose levels within a normal range. Right? And that's what this panel on the left-hand side of the slide is. Now what happens in the cell is that you've got insulin over here. Right? So insulin is over here. It binds to the insulin receptor. And what happens once insulin is binds to the insulin receptor is a couple of things. One is that this glucose transport protein is then moved to the cell membrane. And what happens when this transport protein is moved to the cell membrane? It allows glucose to actually enter into the cell. Without this glucose transporter, glucose cannot enter into the cell. So glucose enters into the cell, and then it can be used as a source of energy. Now the other thing that happens is when insulin binds to the insulin receptor is that you've got changes in protein synthesis, fat synthesis, glycogen synthesis, and the growth and gene expression. Right? So all these changes occur because insulin can bind appropriately to the insulin receptor. Now, physiology of insulin release and action. So what we have here is we have the beta cell in the pancreas, and then we've got peripheral tissue around the body, right? And they're also present. They're definitely present in skeletal muscle. And so what happens is this: so you've got the pancreas, and you've got glucose floating around. And so what happens in the beta cells of the pancreas is, again, there's a different kind of glucose transporter called GLUT2 that basically allows glucose to come in. And the amount of glucose that comes into the beta pancreatic cell is proportional to the amount of glucose in the blood. So if there's more glucose in the blood, more glucose goes into the cell, right? And what happens is when glucose enters into the cell, it activates a series of changes so that calcium goes into the cell. And when calcium goes into the cell, these vesicles that contain insulin basically bind to the cell membrane, and then insulin is released. right? And then when insulin is released, it travels in the systemic circulation, binds to the insulin receptor, and once the insulin it binds to the insulin receptor, as I said, it translocates another glucose transporter, in this case the GLUT4, into the cell membrane so that glucose can come in, and it then acts, the insulin receptor, when it's activated, also acts to have these following changes. Now, what happens is that there are two main types of diabetes. There's a third over here. Gestational diabetes usually develops during pregnancy and usually goes away after pregnancy, right? So we're not going to concern ourselves with gestational diabetes. We're going to focus mainly on type 1 and type 2, right? As you can see over here, type 2 is the more prevalent form. 90% of all diabetes are type 2 diabetes. Type 1 is only 5 to 10%. Type 1 is also called insulin dependent diabetes mellitus because it really depends on the levels of insulin. So in type 1 diabetes, what happens is that these beta cells are destroyed, right? No beta cells around, no insulin released, right? So that's bad. But the good part is that the treatment is basically exogenous insulin, right? So a person isn't producing insulin. What's the treatment? Give them insulin, all right? So that's fairly simple. In type 2 diabetes, what happens is this. So this works, right? Insulin can be released, either low, normal, or high levels of insulin are actually released. But what happens in type 2 is that this receptor isn't responsive. So this receptor doesn't really quite work, and so this doesn't happen, right? So again, insulin levels in type 2 diabetes can be normal or even too high, but it doesn't matter because the problem is the insulin receptor. And so this is called non-insulin dependent diabetes mellitus. And this usually occurs traditionally in a person that's 40 years or above, right? And so what you see here is you can see insulin resistance where the receptor isn't activated by insulin, and it can be found with or without impaired insulin secretion. So it's what it means over here is insulin levels can be either too low, normal, or too high. So one of the big things with a person with diabetes is they need to monitor their blood glucose levels, right? They cannot monitor their insulin levels, but they can monitor their blood glucose levels, right? And so there's several different tests that are used to monitor blood glucose levels and used to actually monitor how well that person is managing their diabetes. So you've got short-term tests and you've got long-term tests. Right? In terms of short-term tests, you've got casual plasma glucose levels. So this is the what happens in booths at local fairs, at malls, at hospitals, where you can just walk up, get your blood tested for glucose levels, no dietary preparation. The second one is oral glucose tolerance tests. So basically what happens is a person is given a sweetened drink, told to wait 2 hours, and then their blood glucose levels are measured. And this basically gives you an indication of how well insulin is working within the body, because if insulin works, then it means that blood glucose will drop over that 2-hour period. And then you've got fasting plasma glucose, where you have no eating or drinking for at least 8 hours, and then a sample of blood is taken and blood glucose measured. All right, so these are the first three are short term. The last one, the fourth one, is long term, and basically this monitors diabetic status over a 3-month period. So again, no preparation, but there's also no cheating on the test, because what this glycated hemoglobin test does is it measures the number or the percentage of red blood cells that have glucose stuck on it, right? And the number of glucose stuck on a red blood cell is proportional to the number of glucose present in the blood over the lifespan of a red blood cell. And we know that red blood cell typically lasts about 120 days. So again, this is what happens, right? So hemoglobin can attach glucose, and it's a permanent attachment, right? So once the glucose enters into the red blood cell and binds to the hemoglobin, it's stuck there. All right, and so the amount of glycated hemoglobin is a reflection of the diabetic status and the management of that person with diabetes over the past 2-3 months. Right, so again, if that person is thought to not manage their diabetes adequately, it would be taken every 3 months. If the glycemic stable targets are stable, it would be done every 6 months. All right, how to manage diabetes. So in type 1, there's no insulin around. So the treatment is to give insulin as a replacement therapy. Right? In type 2, the levels of insulin are secondary, but really what happens is you have what's called insulin resistance, where the receptor doesn't bind to insulin well. And so there's 4 different types of drugs that can be given to actually help to manage the blood glucose levels. What we're going to do now is just talk about the types of insulin. So there's several different types of insulin, right? So there's short duration, rapidly acting insulin that's basically that's administered just before eating, and it works within 15 to 30 minutes. So again, if you eat something just before it give this short rapidly acting insulin, and it helps to decrease blood glucose levels. And then the second one is short duration, slower acting. Again, can be administered 30 minutes before meals, right? Usual route is subcutaneous, can be administered IV. The third type of insulin is intermediate duration, so it lasts for a while, and this is used to control blood glucose levels between meals and especially at night, right? And it's linked to a protein which basically decreases solubility into the systemic bloodstream, so the effects are prolonged and extended. And then the fourth type of insulin is long duration and given really once a day, right? And this helps to control blood glucose levels over a 24-hour period. In this slide, you've got the 4 different types of insulin, and you see here how they work, right? So the blue one is the short duration, fast acting. So you see here, it basically appears as insulin in the blood very quickly to help to decrease blood glucose level as a person is eating, and as well with the short duration, slower acting, whereas the green and the orange preps of insulin are longer duration, right? And they're slower acting. So you see over here, the green takes a while to get up to speed, but it also lasts a long time. So you would give it maybe a couple of times a day, right? Whereas the orange one just gives you a baseline level of insulin. So again, that allows glucose to actually enter into the cells to be used. Now, again, this is used for people with type 1 diabetes, or as well as people with type 2 that aren't producing enough insulin. But one of the main groups of drugs with type 2 diabetes is these 4, right? So the first one is sulfonylureas. Basically what they do is they stimulate insulin release, and it increases insulin sensitivity. So another way for saying increases insulin sensitivity is to decrease insulin resistance, right? And when that happens, what happens is more GLUT4 transport proteins are translocated to the membrane, and so more glucose enters into the cells. So people that are on sulfonylureas might progress to combination therapy within 10 years. And so combination therapies include either sulfonylureas and one or more of these other drugs. Right? The second group of drugs are biguanides. So metformin is an example of that. So what happens with this is it decreases synthesis of glucose by the liver, right? So less glucose produced by liver, and then less glucose is absorbed from the GI tract, and so what happens is that then decreases blood glucose levels. All right, and also biguanides also increase glucose uptake by muscle cells and adipocytes, and so what happens is glucose enters into the cell, and again that helps to decrease blood glucose levels. Glitazones, the next group of drugs, basically increases insulin sensitivity, and so you've got the insulin receptor over here. Insulin can bind, and it can lead to changes inside the cell, as well as an increase in glucose entering into the cells. Right? Glitazones are used as combination therapy to actually facilitate a reduction in blood glucose levels. And then the fourth group of drugs are the alpha glucosidase inhibitors, and what happens is carbs are metabolized by this enzyme, the glucosidase, into monosaccharides. And these monosaccharides are then the ones that can be absorbed by the GI tract into the systemic circulation. And what happens is these glucosidase inhibitors basically inhibit the level of enzyme, and so it stays as complex carbs, and these are then excreted directly without being absorbed first. And again, this has a small effect on its own, so it's used in combination therapy regimens. All right, that's it for now.